Let's move on and talk about thyroid cancer. Typically, you'll be presented with a case in which you have a thyroid nodule, and the question will be whether or not it is cancerous. So one test that you might order is a radioactive iodine uptake test. In a very active gland or tissue, you will see uptake in areas where the thyroid hormone is being made. If it is a nodule, it would be called a hot nodule. And here we see an image of a hot nodule in one part of the thyroid gland. However, if you feel a nodule but there is no uptake on the scan, we call this a cold nodule. And these are most often associated with cancer. Now we'll talk about the main types of thyroid cancer that you need to know for your exam. Each has a set of unique features that you should associate with it. Papillary thyroid carcinoma is the most common type of thyroid cancer, and it carries an excellent prognosis. People who have received radiation to the neck during childhood are at an increased risk for developing this type of cancer. On histology, there are certain key features that you should be looking out for, and one of these are the empty appearing nuclei called orphan Annie-eyes, in reference to the Annie cartoon shown in the image in the lower right. The other histological feature to look out for are psammoma bodies, and these are also associated with this cancer in addition to various other pathologies. So psammoma bodies are also found in papillary renal cell carcinoma, papillary ovarian serous cystadenocarcinoma, meningiomas, mesotheliomas, and prolactinomas. You may want to write this fact down on a separate piece of paper or make a flashcard so you can easily reference this again. It is definitely an important piece of trivia to know. Follicular carcinoma is the next most common type of thyroid cancer and also has generally a pretty good prognosis. Pathologists frequently have a difficult time differentiating follicular carcinoma from simple adenoma, and this is one type of cancer that can't be diagnosed with a fine needle aspiration. It is more common in women, and a unique feature is that it tends to invade vessels. So if it spreads, it is via hematogenous route or through the blood, rather than through lymphatics. Medullary thyroid carcinoma is unique in that it does not come from follicular cells. Rather, it comes from a different type of cell that secretes calcitonin. Do you remember what these cells are called? Right, parafollicular C cells. Remember, C for calcitonin. Histologically, one sees sheets of cells with amyloid stroma, and amyloid, as you may recall, is typically described as staining with Congo red under polarized light, and there is an apple green birefringence. In addition, medullary thyroid carcinoma is also associated with MEN2A and 2B syndromes, which we will discuss at the end of the endocrine pathology section. Another commonly tested thyroid carcinoma is undifferentiated or anaplastic thyroid carcinoma. This is extremely rare and has a terrible prognosis when compared to the other types of cancers. It is much more common in elderly patients and is associated with a p53 tumor suppressor gene mutation. One other tumor that frequently occurs in the thyroid, though it is not derived from intrinsic thyroid tissue, is lymphoma. And what thyroid disorder is typically associated with this? Hashimoto's thyroiditis. Alright, we're leaving the thyroid and moving on to the parathyroid. We'll start with hyperparathyroidism. So what hormone is produced by the parathyroid glands? Right, PTH. And PTH is responsible for increasing calcium resorption and PO for excretion. Now in hyperparathyroidism, your serum calcium levels are elevated. The classic symptoms are remembered with the mnemonic stones, bones, groans, and psychiatric overtones. Stones refers to kidney stones. Because of the increased serum calcium levels, you will be filtering a lot of calcium into the glomerulus, and even though you resorb more with the effect of PTH, you still get calcium in the urine, which is known as hypercalciuria. The types of stones you will see in these patients are calcium oxalate stones, which is actually the most common type of kidney stone overall. Now, the bones. Because you do not have adequate phosphate, you have poor bone mineralization, which can make them much more fragile. Specifically, the bone pathology of hyperparathyroidism is known as osteitis fibrosis cystica. On the left, we have an X-ray showing areas of lucency on the tibias, indicated by the arrows. If we were to examine these bones on a histological section, as we see here on the image on the right, we can see that spaces have formed. This is due to increased osteoclast activity as a result of increased circulating PTH. But recall that it is the osteoblasts that contain the PTH receptor, and it is via the rank ligand receptors that the osteoclasts become activated. The increase in bone breakdown can lead to hemorrhage into the bone, and you can see some extravasated blood in this image, as shown here. And this can eventually result in cyst formation with brown fibrous tissue, hence the name fibrosis cystica. Moving on to the other symptoms, the groans refer to the GI symptoms such as peptic ulcers due to calcium stimulation of gastrin, which then leads to an increase in acid production, acute pancreatitis, and lastly constipation. Psychiatric overtones refers to anxiety and confusion and overt psychosis. Primary hyperparathyroidism is usually caused by a parathyroid adenoma. Less frequently, it can be caused by diffuse glandular hyperplasia. Laboratory findings include hypercalcemia, hypercalciuria, and hypophosphatemia. Also, because bone is being broken down, alkaline phosphatase can also be elevated. Additionally, you might see high levels of cyclic AMP in the urine because PTH binding to PTH receptors activates G proteins, which stimulates the production of cyclic AMP by adenylyl cyclase. When you think of primary hyperparathyroidism, an important group of diseases to recall are MEN2A and MEN2B, which are characterized by parathyroid hyperplasia. As promised, we'll be discussing this at the end of the section. Secondary hyperparathyroidism means that you have hyperparathyroidism secondary to a cause outside of the gland itself. One cause of this is chronic kidney disease. Now, why do you think this is the case? Well, remember that PTH release can be stimulated by low calcium levels. So why would the levels be low in chronic kidney disease? Well, as kidney function worsens, there are fewer and fewer cells producing 1-alpha hydroxylase, which means you get less vitamin D conversion to its active form 1,25 vitamin D. As a result, there is poor absorption of calcium from the GI tract and therefore lower levels of serum calcium. Additionally, if your kidney is not functioning properly, then you have decreased resorption of calcium in the distal tubule, so calcium can be lost in the urine too. Together, these defects stimulate PTH secretion from the parathyroid glands. Overall, the labs in secondary hyperparathyroidism will be similar to primary hyperparathyroidism, except serum calcium levels are still lower than normal because of poor GI absorption. In order to try to restore serum calcium levels, bone is broken down to release calcium. As a result, we have formation of bone lesions that, in renal failure, are known as renal osteodystrophy, which is characterized by subperiosteal thinning. I think of it as a combination of two things, osteoporosis and osteomalacia. Remember, osteoporosis is due to increased osteoclast activity, whereas osteomalacia is due to inadequate vitamin D and leading to low calcium levels and poor bone mineralization. Tertiary hyperparathyroidism occurs as a consequence of long-term secondary hyperparathyroidism. Over time, the parathyroid glands are chronically stimulated and they begin to overcompensate and produce excess PTH. As a result, you get elevated PTH as well as elevated calcium levels. We can see on this table that under the setting of primary and tertiary hyperparathyroidism, we have an elevated PTH despite elevated serum calcium levels, while in secondary hyperparathyroidism, we have low serum calcium but a high PTH, as this is a normal physiologic response to the low calcium levels. You may also see this concept of hyperparathyroidism represented graphically in this manner. So I'd like to briefly orient you to this graph and help you understand where these conditions would be found. Here on the x-axis, we have calcium. On the y-axis, we have PTH. And in the center, we have normal range. So where would you expect to find a patient with primary hyperparathyroidism? In the upper right quadrant, and this is because patients have high serum calcium levels and high PTH levels. Similarly, you will find tertiary hyperparathyroidism also in this upper right hand quadrant. Now, where would you expect to find a patient with chronic kidney disease? Good, the left upper quadrant. And this is because they have secondary hyperparathyroidism, in which their body is responding to low calcium levels and producing more PTH.